Hi, I'm Dr. Randall Thomas at Orthopedic Foot and Ankle Center. Today we're going to talk about insertional Achilles tendinopathy, or commonly known as Achilles tendinitis. The insertional Achilles tendinopathy is where the Achilles inserts to the back of the heel bone. We get inflammation of the tendon. This goes into the heel bone and is responsible for gliding and moving the ankle up and down, and actually is the biggest tendon in the body. This can lead to inflammation with overuse and can be very painful. Some patients will experience a large bump on the back of the heel, or inflammation, kind of redness, almost bruising type of pain at the back of the heel. Common with overuse over time, sometimes seen in weekend warriors, can be a precursor to risk factors of the Achilles, so different than an Achilles rupture, but inflammation of the tendon going into the Achilles itself. Sometimes it can have a spur associated with it as well. Symptoms usually pain at the back of the heel, difficulty fitting into shoes. There can be this large prominence or bump where the Achilles inserts into the back of the heel, usually on the back or posterior aspect or on the outside of the heel. And this can lead to rubbing, blistering, pain, and folks tend to go to wearing shoes that don't have backs to them. This can also lead to some weakness. The biggest symptom I would say is after you sat for a while and get up, it can have a tearing feeling. Or if you slept and got up in the morning, it could have a tearing feeling. So similar to pain at the bottom of the heel, like a plantar fasciitis or heel spur pain, but happening at the back of the heel. The cause is usually a tight Achilles tendon and actually a tight calf muscle. There's a term called equinus, and there's different types of that, where the calf becomes the Achilles tendon. There can be a lot of tightness that is genetic, inherited, or from lack of mobility over time. Can also have to do with overuse, improper shoe gear, can have to do with obesity or kind of body habitus, injuries from the past that have become more chronic. So the cause of this is inflammation of the tendon. There's a bursa sac that sits there as well. You can get bursitis, and a lot of times accompanied by a spur. And that spur and tendon start to break down over time. Diagnosis is by physical exam and x-rays initially. A lot of times we get an MRI to try to determine the extent of the Achilles breakdown. For example, if we see over 50% of Achilles breakdown, there's a different treatment protocol than less than 50%. The spur at the back of the heel will be seen on x-ray as a calcification and extra bone growth into the spur. This spur is literally growing within the Achilles tendon and degenerating or breaking down some of the fibers of the Achilles. The Achilles is a cord-like tendon, and you can have little fibers within that cord, and they can break down from the spur. So typically your physician will palpate or feel the back of the heel, feel a bump of bone, tightness with range of motion at the ankle, and a lot of pain if you're pushing the foot up or dorsiflexing it. Physical therapy, ways of doing topical steroids with ultrasound, anti-inflammatory creams. You want to avoid injections in this, such as steroids, and I would also be very hesitant for any platelet-rich plasma or stem cell type of injections, because that can lead to rupture of this. This is a high-risk condition, and you don't want to have a rupture of the Achilles tendon. Sometimes we have to immobilize patients as well, put them in one of the walking boots for a while, or into a custom brace or an over-the-counter brace, with a combination of anti-inflammatories and those topical creams I mentioned previously. If the non-operative treatment doesn't work, or on advanced imaging like the MRI or ultrasound, we see degeneration of the tendon more than we expect, or it's at risk of rupture, then we go into operative intervention. And the surgery includes going in and opening the Achilles tendon from the back, cleaning out the abnormal fibers, the breakdown, the tendinitis, a lot of times taking out the bursa where we have bursitis, and then getting rid of the heel spur. By getting rid of the heel spur, we don't see the degeneration of the tendon. If enough of the native tendon or the person's own tendon is intact, then we don't have to graft it, and we just put that right back into the heel. There are ways to anchor this back into the heel without metallic implants, so there's less risk associated with this. And there's also other ways to go about it from a side approach, what we call a lateral approach, where the incision's on the side of the foot instead of directly at the back. That's a way to get to the spur, less invasive in regards to breaking down the tendon and risk, and you can also access the bursa. In very severe cases where the Achilles is completely degenerated or goes on to tearing, sometimes we have to do a tendon transfer. You hear this commonly called an FHL transfer or flexor hallucis longus tendon transfer. And that's where we borrow a tendon right next to the Achilles and we use it in its place. So you repair the Achilles, borrow a tendon that's normal, and put that into its place to do the repair. That can sometimes lead to a little bit of decreased flexion at the big toe because we're borrowing a tendon that goes to that toe. But typically patients do very well with this, and after recovery can get back to their activities of daily living. The recovery process following surgery can vary. If we do a lateral approach, less invasive, this is not as long of a downtime, usually about 6 weeks of non-weight bearing and then going into a boot and doing therapy. If we go with an open approach, just doing the Achilles, about the same time, 6 to 8 weeks of non-weight bearing, then going into a boot and therapy. If we have to do a tendon transfer, sometimes we'll protect that longer, having the patients wait at least 8 weeks for non-weight bearing. Then we get them into a boot and going to physical therapy at a slower pace. Sometimes we have to wear a brace for a few months afterwards as well, but eventually we can wean that into wearing just a shoe and even being barefoot at times. And there really would be no restrictions as far as activity. Once we can get back to functional status, patients can return to sport, they can return to their activities of daily living, maybe a little bit more cautious with certain high impact activities and putting it at risk. But the goal would be by 6 months to be back to running, jumping, lateral movements. Could take up to a year with the Achilles or longer to see swelling and a final result. Yeah, the risks are inherent to surgery in regards to anesthesia and procedures themselves. Anytime we're opening up the skin, there's risk for infection. We're very cautious with blood clots in the Achilles surgeries just because of the relationship to the calf, and we typically treat with anticoagulants, and that's dependent on each patient and the doctor how they want to treat that. The other risk would be re-rupture, which is rare. We need the patient to be compliant and stay off of it and give it time to heal. We don't want to go into a full rupture, which would then be a subsequent surgery and a much longer time for recovery. We don't see the recurrence of the bursitis because that's usually taken out. We usually don't see recurrence of the spur, and if we do, it's minimal in years down the line. So the risks are actually fairly low for this procedure. Patients always want to know if they'll be able to get back to their regular activity following the surgery. This can vary by the patient, but we would expect everyone to get back to their baseline activities. They may not get back to doing more than they were before, but at least back to where they were, including high-impact sports, running and jumping, even without having to wear a brace. The Achilles can be fraught with taking a long time to heal, which you hear a lot of that with professional athletes. But in this case, if people follow our protocols, usually by 6 months they're back to their baseline activities. After a year, certainly doing very well with this. So I would expect people to get back to their activities. Some like to make modifications to the activities they do eventually, but I would not expect restrictions once you get through a successful surgery and recovery.